Dr. Chinyere.A.Ugorji, MD, MBA, on Dr. Drchikitomentoring Iridiscence educational show, a Rich Higher initiative. And I would like to welcome anyone who is watching this show currently. We have discussed various health topics from a personal perspective with the Health Insurance Portability and Accountability Act. I have a career interest in healthcare, graduate medical education, public health, and the White House internship. I would like to share some quotes with you. At each and every juncture of our history, somebody has been audacious enough to say, we could do better, and more often than not, it's been young people who have done it. President Barack Obama, February 2nd, 2007. This program will mentor and cultivate young leaders of today and tomorrow, and I am proud that they will have this opportunity to serve. I look forward to working with those who are selected to participate, and I want to commend all who apply for their desire through public service to forge a brighter future for our country. President Barack Obama, May 22nd, 2009. Education is the key to success for so many kids, and my goal specifically is to reach out directly to young people and encourage them to take charge of their futures and complete an education beyond high school. First Lady Michelle Obama, January 16, 2014. Education is indispensable to the success of every individual and is a motivating factor behind my graduate medical education curriculum review and interest in the Rich Higher initiative by the First Lady Michelle Obama, inspired by this quote by the First Lady Michelle Obama and a determination to focus on education. I would also like to share my biography with you. The brain, a powerful tool for creating the future. The stethoscope, an astute diagnostic tool. The book, the final piece of the puzzle in creating education. Why did I choose to become a physician? Maybe because I was born a leader. Maybe because I like helping people. Maybe because I think it makes me cool. Maybe because I feel I can be a source of support, a balm in the midst of disease, poverty, and mental anguish. To be a physician, you have to have a sincere love for people and a sincere desire to help people. 2014 till date, Masters in Public Health, Core Social and Behavioral Sciences at Capella University, Minneapolis, Minnesota, and a current project on domestic violence. Graduate medical education application, White House leadership application, non-licensed physician, graduate medical educator, community educator, caregiving certified nurse aide, patient care technician, and successful completion of neuropsychiatric evaluation, objective structure clinical skill evaluation, clinical skill workshops, advocacy with the American College of Physicians, American Academy of Family Physicians, American College of Obstetrics and Gynecology, American Pediatrics Association, American Psychiatric Association, Dr. Drchikitomentoring Iridiscence education, and various other collaborative organizations. May 2008 to September 2013, Masters in Business Administration, Core Public Health Administration from Davenport University, Traverse City, Michigan. March 2012, Psychiatry Research Experience from the University of Texas, Texas Psychiatry Department with Dr. Carol Nutt, MD, and then adults, MSW, on psychoeducation and hepatitis C and alcohol behaviors. 2010 to date, research on psychiatric, cultural, and contextual arbitration and domestic violence with personal experiences integrated into psychiatry research experiences from the University of Texas Southwestern Psychiatry Department with Dr. Carol Nutt, MD, and then adults, MSW, on psychoeducation, hepatitis C, and alcohol behaviors. and behavioral science rotation from Southern Illinois University Family Medicine Residency Program, Springfield, Illinois. May 2012, separation legal divorce proceeding. March 2011 to May 2012, graduate medical education at Southern Illinois University Family Medicine Residency Program, Springfield, Illinois, after the National Residency Matching Program, paramount to interviewing at various graduate medical education programs. As a pregnant infant, knocking the socks of the American Board of Family Medicine including examination, using the program director, Dr. Chinyere.A.Ugorji, MD's lexicon, and completing clinical rotations in surgery outpatients, community medicine, behavioral science, family medicine training service, obstetrics and gynecology, continuity clinic, behavioral science, family medicine training service, obstetrics and gynecology, continuity clinic, didactics, neuropsychiatric evaluation, and successful completion of objective clinical skill evaluation and termination of residency contracts, conglomerates of graduate medical education. December 2010, graduate medical education at Huntsville Family Medicine Residency Program in Family Medicine Training Service with Dr. Mary Bustani, MD, the Program Director. July 2010, graduate medical education at St. Elizabeth and Mary's Family Medicine Residency in Family Medicine with Dr. Saida Zahidi, MD, the Program Director Emeritus. July 2010, successful completion of the United States Medical Licensing Examination Step 3 with a score of 88 on 212. May 2010, medical education at Harris Fort Worth Methodist Hospital, Fort Worth, Texas, in internal medicine with Dr. Fidelis Imini, MD, and internist. March 2009 to September 2009, graduate medical education at Henry Ford Internal Medicine Residency Program in Detroit, Michigan, paramount to interviewing at 21 graduate medical education programs nationwide, completing clinical rotations working in pulmonary medicine and critical care medicine with Dr. Alvin Bowles, a pulmonologist and critical care physician, and in family medicine training service with Dr. Kimberly Baker-Janal, the program director, continuity clinic, didactics, neuropsychiatric evaluation, and termination of residency contract, conglomerate of graduate medical education. August 2008, United States Naturalization and Citizenship. March 2007, successful completion of the United States Medical Licensing Examination Step 1 with a score of 88 or 212. June 2007, successful completion of the United States Medical Licensing Examination Step 2 clinical skills. Step 2 clinical knowledge with a score of 98 or 237. July 2010, successful completion of the United States Medical Licensing Examination Step 3. August 2007, successful completion of the United States Medical Licensing Examination Step 2 clinical knowledge with a score of 98 or 237. 2003, caregiving, certified nurse aid and non-health care jobs. 2003, United States of America green card with the United States of America diversity visa lottery. January 1998 to February 2003, medicine and surgery, Imo State University, first year admission and scholarship. January 1992 to December 1998, secondary school, high school diploma, Owerri Girls Secondary School, Nigeria, 9As, 7A1s. January 1986 to December 1991, primary school, Unity Primary School, Owerri, Nigeria, first top 3 students in admission to secondary school for primary 5. What are my future goals? My future goals include completion of accreditation council of graduate medical education, core competency training in graduate medical education and healthcare reform within the next 3 years, with goals of overcoming clinical skill limitations and medical knowledge in graduate medical education with continuous collaborative conferences. What are my strengths? My strengths include my interest in healthcare, education, and successful completion of neuropsychiatric evaluation and objective structured clinical skill evaluation, conglomerate of graduate medical education. What are my weaknesses? My weaknesses include limitations in effective healthcare delivery attributable to my exiguous graduate medical education. How do I handle challenges? I love challenges and I emerge mature and resilient, utilizing hard work, effective um, um, professional resources, and collaborative teamwork. How do I handle confrontations? Communication is the key to handling confrontation successfully, utilizing a good understanding of the personality, the role, and perspective of team. Who are my heroes? My heroes include healthcare reform and educational leaders. What are my hobbies? My hobbies include healthcare, education, charity walks, and dance arts. Why did I choose healthcare? I chose healthcare because of the continuity of care, the longitudinal care, the healthcare delivery models, the specialization opportunities available in this field. After completion of clinical rotations and being part of effective healthcare delivery as part of a collaborative team. Why am I interested in graduate medical education? Collaborative research of graduate medical education programs nationwide with diverse graduate medical education opportunities and contribution towards healthcare reform are reasons behind my interest in graduate medical education. Why should any graduate medical education program pick me as a resident? My dedication to healthcare, medicine, and my career experiences are reasons for graduate medical education programs to incorporate me into graduate medical education. What can I offer graduate medical education? I can offer graduate medical education programs, dedication to healthcare, education, and collaborative teamwork within the next 1 to 3 years. Do I have a criminal record? I have not been convicted of a criminal crime in the United States legal system. Why am I interested in domestic violence? Child support exemptions, penitentiary programs, domestic violence, and personal experiences as part of the current projects are reasons behind my interest in domestic violence. Nearly 2 out of 3 Americans 50 years of age or older know a victim of domestic violence or sexual assault. And domestic violence homicides claim the lives of 3 women every day. www.whitehouse.gov 2014. What is the concept of the patient-centered medical home? The patient-centered medical home is a primary health care delivery model emphasizing collaborative, continuous care coordination and communication by a team-based model led by a physician, a physician's assistant, or a nurse practitioner. Maximizing healthcare outcomes, utilizing health information technology, current practices and recommendations with a flow sheet ranging from recognition, acquisition for patient-centered medical homes, training for various practice sites, and transforming practice standards and maintenance of patient-centered medical home standards an integral part of graduate medical education. Building on the work of a large and growing community, the Agency for Healthcare Research and Quality, AHRQ, defines a medical home not simply as a place, but as a model of the organization of primary care that delivers the core functions of primary health care. Agency for Healthcare Research and Quality, 2014. What is the Affordable Care Act? The Affordable Care Act, or the Patient Protection and Affordable Care Act, PPACA, popularly known as Obamacare, is a federal health care institute signed into law by President Barack Obama on March 23, 2010. And the Healthcare and Education and Reconciliation Act represents the most significant regulatory overhaul of the United States health healthcare system since the passage of Medicare and Medicaid in 1965, enacted with the goals of increasing the quality and affordability of health insurance, lowering the uninsured rate, expanding public and private insurance with mechanisms including subsidies, mandates, and insurance exchanges. The Affordable Care Act puts consumers back in charge of their health care. U.S. Department of Health and Human Services, 2014. What is the healthcare insurance marketplace? The healthcare insurance marketplace is for healthcare delivery on a central website configured based on the Kaiser Family Foundation calculator, with provisions for healthcare providers to offer patients all available options based on age, medical conditions, and income. In a special enrollment period which ended March 31st, 2014, restarting on November 15, 2014, spanning a 2-week period, but is still available for Medicaid, special enrollment periods, children health insurance, shop coverage for small businesses, enrollment for members of federally recognized tribes and Alaska Native shareholders. A 70-year-old individual without any health insurance, with or without a medical condition, like me or the average American, will have effective health care delivery with insurance calculated with the Kaiser Family Foundation calculator and the healthcare insurance marketplace based on his age, medical conditions, and income. Some important terms about the healthcare insurance marketplace include the following. A premium. A premium is the fixed amount paid for care irrespective of healthcare delivery. A co-payment. A co-payment is the amount paid, is the fixed amount paid for care after paying the deductible, while the insurance covers remaining costs. A co-insurance. A co-insurance is the percentage paid for care by the insured out of pocket maximum. This is the total amount which the insured individual has to pay before the insurance assumes total costs. Advanced premium tax credits. These tax credits are applied directly to your monthly premiums, resulting in lower costs immediately. What is meaningful use of electronic health records? Meaningful use of electronic health records are incentive standardized criteria set in place by the Centers of Medicare and Medicaid, integrating electronic health records into effective healthcare delivery, collaboration among healthcare systems with improved healthcare delivery and patient empowerment and care. With an evolving system ranging from stage 1 in 2011 to 2012 with data capture and sharing, stage 2 in 2014 with advanced clinical processes, and stage 3 in 2016 with improved outcomes. What does personal practice satisfaction experience mean to me? Practice satisfaction in my healthcare practice, Drchikitomentoring healthcare practice Iridiscence education, with graduate medical education, free healthcare, community education and health fairs at the local community church, the 8th Ward, South Dallas, 2013, and affiliation with the Leukemia and Lymphoma Foundation was a practice satisfaction opportunity for improvement in accreditation, core competency training in patient care, medical knowledge, practice-based knowledge, system-based knowledge, professionalism, communication and interpersonal skills. What is teamwork in the concept of healthcare? Teamwork in healthcare is collaboration of interdisciplinary teams of medical practitioners from different professions, sharing a common patient population, goals and responsibilities, integrating healthcare delivery models into effective healthcare delivery. What is end-of-life care? End-of-life care are ethical considerations in healthcare delivery to patients and families facing terminal illnesses, including pain management, resuscitation and life-sustaining measures, a component of graduate medical education. What is cultural competency? Cultural competency is a set of congruent behaviors, attitudes, and policies necessary for effective healthcare delivery in cross-cultural situations, a component of graduate medical education. What is work-life balance in graduate medical education? Work-life balance integral to emerging as a balanced and competent resident for healthcare delivery and healthcare reform, integrating continuous education, family, hobbies, and a healthy lifestyle with professional collaboration. Coming soon, teach me something non-medical in 5 minutes. Evaluation and feedback in graduate medical education. Graduate medical education curriculum review. American, yeah, what is mentorship in graduate medical education or career development? I would also like to share my personal statement with you. Internal medicine personal statement. My choice to be a physician stems from educational and physician leaders from early developmental years to graduate medical education, and real life stories of patients whose life have been transformed by healthcare in my family, patient care, and various charity works, and be a part of effective, innovative, cutting edge healthcare delivery. Hello everyone, I'm Dr. Chinyere.A.Ugorji, MD, a 2007 graduate of American International School of Medicine. My typical introduction to community educational youth stream shows, discussing the quintessential skills for patient encounters and components of the clinical decision-making process, and the role of graduate medical education curriculum with its diversified topics ranging from emergency protocols, patient encounter, coding and billing, electronic health records and practice management, contributing towards effective healthcare delivery. Healthcare integrates the fine art of addressing patient symptoms and physical examination findings, integrating humanitarian qualities, pharmacology, and psychotherapy, which have worked in the past. Healthcare reform with continuous innovative healthcare delivery, creating healthcare opportunities from the United States of America, Taiwan, Africa, and Russia, with healthcare professionals, systems, and health information technology, with personalized patient-centered approach, didactics, and healthcare delivery systems. Specialization opportunities, especially hematology and oncology, makes internal medicine my choice of specialty. My clinical career has been shaped by medical education and United States medical licensing examination scores of Step 1, Step 2 clinical knowledge, Step 2 clinical skills, Step 3 scores of 88 or 212, 98 or 257, pass 88 or 212, and improved to training from clinical rotations in the United States of America at Atlanta Medical Center and Crawford Blunt Hospital, Atlanta, Georgia. Observerships at Texas Health Harris Methodist Hospital, Fort Worth. In internal medicine with Dr. Fidelis Udini and Huntsville Family Medicine Residency Program, Huntsville, Alabama. In family medicine in training service with the program director, Dr. Mary Pistani and the inpatient team. Externship at Resurrection St. Elizabeth's Hospital Family Medicine Residency Program in family medicine with the program director emeritus, Dr. Saida Sahidi, and graduate medical education training at Henry Ford Internal Medicine Residency and SIU Family Medicine Residency Program, Springfield, Illinois, with inpatient, outpatient, and obstetrics and gynecology rotation with program directors Dr. Kimberly Baker Jamal and Dr. Janet Albers, and continuously updated with graduate medical education and caregiving in Dallas, Texas, and enhanced with a Master's in Business Administration, core Public Health Administration, and ongoing Public Health at Capella University, Minneapolis, Minnesota. It was amazing to see the changes which occurred in the past few weeks in the 15-year-old Caucasian male with caregiving, incorporating occupational therapy, speech therapy, and physical therapy with past medical history of cerebral palsy, whose chief complaint was an abnormal muscle tone, asymmetrical crawling or failure to crawl, growth disturbance and failure to thrive, and gross motor developmental delay, which has improved progressively over the past few months, and family history of genetic disorders and current preventive care on baclofen, gabapentin, 15 milligrams twice daily orally, and phenobarbital, 100 milligrams or 10 milliliters, and no known drug allergies with concordant review of systems and physical examination findings of decreased visual acuity of 20 over 200, 2 centimeters well-healed scar in the umbilical region with a gastrostomy tube, 2 over 5 muscle strength, decreased muscle tone and bulk, decreased coordination, normal sensory function, 3 plus deep tendon reflexes, contractures, decreased range of motion, differential diagnosis of inherited metabolic disorders, metabolic myopathies, metabolic neuropathy, movement disorders in individuals with developmental disabilities, traumatic peripheral nerve lesions, tumors of the conus and cauda equina, and vascular malformations of the spinal cord, with laboratory orders and findings of elevated serum lactate, pyruvate levels, ammonia levels, elevated organic and amino acids, cerebrospinal protein, chromosomal analysis, imaging of computed tomography, CT scanning, magnetic resonance imaging, MRI, electromyography, EMG, nerve conduction studies with evoked potentials, consult with neurology leading to an assessment of cerebral palsy with a plan of continuing medications, feeding with gastrostomy tube, physical therapy, occupational therapy, and speech therapy. Follow up in 3 months and coding and billing of ICD-9, 343, ICD-10, GAT, and billing of 99205 as a new patient due to the comprehensive history, the physical examination, and high complexity decision making done in 60 minutes. The 33-year-old African American was in severe distress and cried uncontrollably when she was brought in by the ambulance into the emergency room and said, "I was raped," as the chief complained 1 hour ago, with history of present illness of inflicted physical injuries and unprotected sexual abuse, past medical history of depression, past surgical history of a cesarean section 5 years ago, obstetric history of last menstrual period 4 weeks ago every 4 weeks on oral contraceptives, current preventive care, social history of unemployment, high school graduate, single and use of marijuana for 7 years, and no known drug allergies with concordant review of systems, physical examination findings of severe distress, bleeding lacerations on face, arms and trunks, vaginal lacerations, and differential diagnosis of blunt abdominal trauma, abruptio placenta, acute coronary syndrome, alcohol and substance abuse evaluation, soft tissue injury, anxiety, asthma, vaginitis and malingering, and laboratory orders of urine or serum pregnancy tests, serologic tests for syphilis, hepatitis B, human immunodeficiency disease, vaginal cultures for wet mouths, gonorrhea, chlamydia, trichomonas vaginalis, bacterial vaginosis and candidiasis, procedures of colposcopy, consults of obstetrics and gynecology and psychiatry, an assessment of sexual abuse and treatment plan of ceftriaxone 125 mg intramuscularly in a single dose, metronidazole 2 grams orally as a single dose, and azithromycin 1 gram orally in a single dose, and 2 oral tablets and 2 tablets 12 hours later for pregnancy prophylaxis, tetanus, hepatitis B prophylaxis, and counseling with a sexual counselor. Follow up with obstetrics and gynecology in 1 week, and pulling and billing of ICD-9 E960.1 T74.2 and billing of 99202 as a new patient with detailed history, physical examination, and low complexity decision making in 30 minutes. It was a great learning opportunity with the obstetrics and gynecology team at Southern Illinois University Family Medicine Residency Program, when the 33-year-old Asian female came and said, "I'm having uterine contractions and a headache as a chief complaint, with history of present illness of uterine contractions every 5 minutes, rupture of membranes with medium amounts of clear amniotic fluids, fetal movement every 5 minutes, lightning, changes in breathing, frequent urination and no vaginal bleeding, past medical history of urinary tract infection, obstetrics History of first gestation, no preterm. 10. Aborted or live pregnancies, current preventive care. Social history of married, physician, graduate school, living with husband and exercises 3 times a week, and no known drug allergies. Concordant review of systems and physical examination findings of hypertension. Cephalic left occipital anterior presentation. Contractions every 5 minutes and fetal heart rate of 150 beats per minute. And a digital vaginal examination results of 10 cm cervical dilation, 100% fixed. Anterior cervix with a firm consistency at 0 station. Differential diagnosis of normal level 1 delivery. Pre-eclampsia, urinary tract infection, cervical lesions, ectopic pregnancy, myomas and ovarian tumors. And laboratory orders of complete blood count, CBC, blood typing and screening, urinalysis, sodium alanine aminotransferase, ALT, and aspartate aminotransferase, AST levels, creatinine, uric acid, 24-hour urine collection for protein and creatinine, peripheral blood smear, serum lactate dehydrogenase, LDH level, indirect bilirubin, coagulation profile, prothrombin time, PT, activated plasma tromboplastin time, APTT, and fibrinogen, imaging of head computed tomography, trans-abdominal ultrasonography, umbilical artery Doppler ultrasonography, cardiotography, pulling tests, nitrazine paper tests, and FEN tests, which are usually performed, imaging of external tochometry, monitoring an intrauterine pressure catheter, bedside ultrasonography, cardiotography, electronic fetal monitoring, and fetal scalp electrode, fetal pulse oximetry, procedures of establishment of intravenous access, consults of obstetrics and gynecology, with assessment of labor and delivery, pre-eclampsia and treatment plan of delivery and pain management, labor augmentation of blood pressure control with meperidine 25 to 50 milligrams, oxytocin 1 milli international unit per minute intravenously, and hydrolazine 5 milligram intravenously, and delivery of the fetus and placenta. Follow up in 1 week after discharge. Coding and billing of ICD-9, ICD-10, labor and delivery 650-080. Pre-eclampsia ICD-9, ICD-9-10 642.4, 642.7, and 011014, and billing for 99215 for comprehensive history, physical examination, and high complexity decision making in 40 minutes. The Family Medicine Training Service rotation at Henry Ford Internal Medicine Residency Program, with the program director, improved my clinical acumen with a 40-year-old African American male who said, "I have abdominal pain as a chief complaint for 2 days, and history of present illness of fatigue, malaise, 9/10 sharp, constant, non-radiating epigastric pain, nausea and vomiting of non-bloody food contents, pathological history of diabetes mellitus type 2, obstetrics and gynecology history of last menstrual period 4 weeks ago, every 4 weeks, lasting for 4 days, and use of 2 pads daily. No history of sexually transmitted diseases, and currently on oral contraceptives. Current preventive care. Social history of college graduate, unemployed, lives with family, married with husband and 3 children, and no known drug allergies. Concordant review of systems and physical examination findings of mild distress. Ketone bread odor, dry mucous membranes, reproducible epigastric pain. Differential diagnosis of alcoholic ketoacidosis, appendicitis, hyposmolar coma, electrolyte imbalance, lactic acidosis, metabolic acidosis, myocardial infarction, acute pancreatitis, and pneumonia, and laboratory orders of urine pregnancy tests, serum blood glucose, comprehensive metabolic panel, arterial blood gas, urinalysis for elevated ketones and beta hydroxybutyrate, serum osmolality, urine osmolality, amylase, lipase, blood culture, erythrocyte sedimentation rate, C-reactive proteins, procalcitonin levels, cerebrospinal fluid analysis, lumbar puncture with positive findings of positive blood culture, images of chest radiography, magnetic resonance imaging, computed tomography, electrocardiography, telemetry, assessment of diabetic ketoacidosis and bacteremia, and plan of rehydration with isotonic sodium chloride replaced with 5 to 10% dextrose with half isotonic sodium chloride solution, switching hyperglycemic therapy to regular insulin humulin 6 units per hour per 15 milliliters per hour therapy, potassium chloride kedol 10 milli equivalent per hour, antibiotic therapy of ceftriaxone 1 gram daily intravenously, follow up after 2 weeks of discharge to home, coding of ICD-9, ICD-10, 450 E10.1 to E14.1, and billing of 99205 for a new patient with comprehensive history, physical examination, and high complexity decision making in 60 minutes. My interest in the American Academy of Family Physicians Star Wars smoking cessation campaign started subsequent to care delivery to a 70-year-old African American male who presented to the emergency room and said, "I have a cough," as the chief complaint and history of present illness of cough, productive of greenish sputum, subjective fever, shortness of breath, 8/10 constant non-radiating pleurotic chest pain for the past 2 days, past medical history of chronic obstructive pulmonary disease, current preventive care, social history of graduate school, lawyer, married with 4 children, living with family, exercises 3 times a week, smokes 1 pack of cigarette per day for the past 40 years, social drinker, on albuterol or ipratropium convivent 100 micrograms per 20 microgram every 6 hours, and no known drug allergies, with concordant review of system, physical examination findings of severe respiratory distress, tachypnea, fever of 100 degrees, increased jugular venous pressure, cyanosis, elevated jugular venous pulse, JVP, hyperinflation, with barial chest, wheezing, diffusely decreased breath sounds, hyperresonance on percussion, prolonged expiration, cyanosis and peripheral edema, and differential diagnosis of alpha-1 antitrypsin deficiency, bronchitis, emphysema, pulmonary embolism and asthma, and laboratory orders of complete blood count, comprehensive metabolic panel, arterial blood gas (ABG), alpha-1 antitrypsin level, sputum evaluation, serum B-type natriuretic peptide, imaging of chest radiography, computed tomography, 2-dimensional echocardiography, pulmonary function test. The distance walked in 6 minutes, 6 mWd. Electrocardiography, right-sided heart catheterization, consult with pulmonology and infectious disease, an assessment of chronic obstructive pulmonary disease exacerbation, and treatment plan of albuterol, Proventil nebulizer solution, 0.5 ml of 0.5% solution, 2.5 milligram over 5 to 15 minutes, over 4 to 8 hours, as needed for shortness of breath. Ipratropium intravent nebulizer, 2.5 ml 500 mcg every 6 to 8 hours, as needed for shortness of breath. Methylprednisolone, solumedrol, 60 milligrams intravenously and orally when tolerating oral intake. And doxycycline vibramycin, 100 milligrams twice daily intravenously and orally when tolerating oral intake. Follow up with family physician in 1 week after discharge, and coding of ICD-9, ICD-10, 490 to 496, J44.1, and billing of 99205 for a new patient with comprehensive history and physical examination and high complexity decision making in 60 minutes. I was the intern on call when a 60-year-old African American male was brought into the emergency room and said, "I have a chest pain." As the chief complaint and history of present illness of 9/10 constant sharp left chest pain, radiating to the left arm, worsened by exertion and relieved by rest for the past 1 day, diaphoresis, and nausea and vomiting of non-violent food products, personal history of hypertension, current preventive care, social history of college graduate, married with 1 child, living with family, exercises 3 times daily, Tobacco smoking of 1 pack per day for the past 10 years. Social drinker. On hydrochlorothiazide at 50 milligram once daily and no known drug allergies. Concordant review of systems. Physical examination findings of severe distress, elevated blood pressure, fever of 100 degrees, irregular pulse, increased jugular venous pulsation, copper wiring, arterial narrowing and hemorrhages on fundoscopic examination, coarse crackles in bilateral lung fields, displaced apical impulse, S3 and 4/6 systolic murmur in the left sternal border, non-pitting peripheral edema with differential diagnosis of acute coronary syndrome, angina pectoris, anxiety disorder, aortic dissection, aortic regurgitation, aortic stenosis, asthma, and biliary tract disease. Laboratory orders of cardiac biomarkers of creatinine kinase, troponin, and lactate dehydrogenase, complete blood count, comprehensive metabolic panel, urinalysis, lipid profile, and C-reactive protein, imaging of electrocardiogram with ST elevation, ST depression on Q waves, stress echocardiography, coronary artery calcium scoring, and assessment of myocardial infarction and plan of intravenous access, supplemental oxygen, pulse oximetry, aspirin 325 milligrams orally, or Zoprin, nitroglycerin 0.3 milligrams sublingually every 5 minutes, clopidogrel, Plavix, follow up in 4 weeks, coding of ICD-9 10-412-125.2, and billing of a new patient 99204, comprehensive history of physical examination and moderate complexity decision making in 45 minutes. Continuity clinic was an enjoyable collaborative environment with diverse patients, including the 50-year-old Caucasian male who came to the continuity clinic and said, "I have a knee pain" as the chief complaint, with history of present illness, of difficulty performing activities of daily living, joint pain, fever, malaise, which is worse in the morning, pathological history of hypertension for 10 years, current preventive care, social history of college graduate, teacher, living alone, single, social drinker, on ibuprofen 800 milligrams once a day, orally as needed for pain and no known drug allergies. Concordant review of systems and physical examination findings of inflammation, deformity, reproducible pain or palpation of the joints of the upper and lower extremities and decreased range of motion, differential diagnosis of fibromyalgia, Lyme's disease, myelodysplastic syndrome, osteoarthritis, paraneoplastic syndromes, polychondritis, polymyalgia rheumatica, psoriatic arthritis, and sarcoidosis. Laboratory orders of comprehensive metabolic panel, complete blood count, erythrocyte sedimentation rate, C-reactive protein level, rheumatoid factor assay, anti-nuclear antibody assay, anti-cyclic citrulated peptide, anti-mutated citrullinated fermenting assays, and C-reactive protein. Imaging of involved joints, including radiography, magnetic resonance imaging, ultrasonography of joints, joint aspiration and analysis of synovial fluid for gram stain, cell count, culture serum glucose, assessment of rheumatoid arthritis and treatment plan of heat and cold therapy, orthopics and splints, therapeutic exercise, occupational therapy, adaptive equipment, ibuprofen, Advil 800 milligrams orally every 4 to 6 hours, methotrexate, Trexal 7.5 milligrams orally as a single weekly dose, follow up in 1 month, coding of ICD-9, ICD-10 714.0, M06.9, and billing of 99214 for established patients with detailed history, physical examination, and moderate complexity decision making in 25 minutes. My understanding of the intricate connection behind gastrointestinal pathology and psychiatric disorders broadened with patient care to a 28-year-old Asian female who came into the clinic and said, I have diarrhea as a chief complaint. With history of present illness of diarrhea, of mucus stool, 8/10 left lower quadrant, constant dull, aching, non-radiating abdominal pain, abdominal distension related to stress, meeting the rule 3 criteria for the diagnosis of irritable bowel syndrome, past medical history of depression, current preventive care, social history of college graduate, nurse, living alone, single, exercises 3 times a week and no known drug allergies, concordant review of systems, physical examination findings of mild distress, reproducible left lower quadrant abdominal pain and palpation, differential diagnosis of abdominal angina, anxiety disorders, bacterial overgrowth syndrome, biliary colic, biliary disease, celiac screw, chronic mesenteric ischemia, collagenous and lymphocytic colitis and colon cancer, laboratory findings of complete blood count, comprehensive metabolic panel, stool examinations for ova and parasites, enteric pathogens, leukocytes, Clostridium difficile toxin and cardiac antigen. Hydrogen breath testing, tissue transglutaminase antibody testing and small bowel biopsy. Thyroid function test, serum calcium, erythrocyte sedimentation rate, C-reactive protein, imaging of upper GI barium study with small bowel follow-through, double contrast barium enema, gallbladder ultrasonography, abdominal computed tomography scan, and assessment of irritable bowel syndrome and treatment plan of psychological support, dietary measures, and dicyclomine bentyl 20 milligrams orally every 6 hours, loperamide, Imodium 4 milligrams initially, and then 2 milligrams after each dose 2. Imipramine, dofranil 75 milligrams orally every day, alocitron, Lotronex 0.5 milligrams orally every 12 hours. Follow up in 1 week. Coding of ICD-9, ICD-10, 564.1, K58, and billing of 99202 as a new patient with expanded focused history and physical examination and straightforward decision making in 20 minutes. My interest in hematology and oncology started after patient care to the African American 11-year-old Bill, who came to the clinic and said, I have abdominal pain as a chief complaint, with history of present illness and generalized pain, fever and failure to thrive, past medical history of sickle cell disease, current preventive care, social history of living with family, on ibuprofen and no known drug allergies, concordant review of systems and physical examination findings of hypertension and tachycardia, tachypnea, dyspnea and fever, scleral icterus present, abnormal or corkscrew-shaped blood vessels, pale mucous membranes, systolic murmur over the entire pericardium, splenomegaly, reproducible abdominal pain, inflammation, pain and decreased range of motion of the extremities, concordant review of systems, differential diagnosis of valvular heart disease, septic arthritis, sepsis, upper respiratory tract infection, aortic arch syndrome and hemolytic anemia, laboratory orders of comprehensive metabolic panel, complete blood count, erythrocyte sedimentation rate, urinalysis, blood culture, arterial blood gas, imaging, studies of radiography, magnetic resonance imaging, computed tomography, magnetic resonance imaging, transcranial Doppler ultrasonography, abdominal ultrasonography, echocardiography, assessment of sickle cell disease and treatment of hydroxyurea, Drchikitomentoring 20 milligrams per kilogram orally every day, oxycodone, and aspirin, Pecodan, 1 tablet orally every 6 hours as needed for pain, folic acid, 4V, 400 milligram microgram per day orally, cefuroxime, 500 milligrams orally every 12 hours for 10 days, sildenafil, reversible intravenously, 2.5 milligram coding of ICD-9, ICD-10 to 82.60, D57.1, and billing of 99205 as a new patient with comprehensive history and physical examination and high complexity decision making in 60 minutes. This synopsis portrays a typical day in the life of an intern with patient care and with Accreditation Council graduate medical education core competency training from medical school, supervised by a resident while maintaining a balanced life with hobbies and healthy mental and physical habits, which I hope to contribute by providing a collaborative environment for graduate medical education and awareness about education and preventive health with the Reach Higher initiative of the First Lady Michelle Obama, with my hobbies of Zumba dancing and charity works on Iridiscence, on Drchikitomentoring, Iridiscence education, Ustream, YouTube, Cisco WebEx, Brain Shack Show, and I resumed joint custody of my 3-year-old as a single mother while achieving my goals of chronic medical education training. I would also like to share my family medicine personal statements. My choice to be a physician stems from educational and physician leaders from early developmental years to chronic medical education and real life stories of patients whose lives have been transformed by healthcare in their family, patient care, and various charity works, and be a part of effective, innovative, cutting-edge healthcare delivery. Hello everyone, I'm Dr. Chinyere.A.Ugorji, MD, a 2007 graduate of American International School of Medicine. My typical introduction to community educational use stream shows discussing the quintessential skills for patient encounters and components of the clinical decision-making process and the role of graduate medical education curriculum with its diversified topics ranging from emergency protocols, patient encounter, coding and billing, electronic health records and practice management, contributing towards effective healthcare delivery. Healthcare integrates the fine act of addressing patient symptoms and physical examination findings, integrating humanitarian qualities, oncology, and psychotherapy, which have worked in the past, with continuous innovative healthcare delivery, creating healthcare opportunities from the United States of America, Taiwan, Africa, and Russia with healthcare professionals, systems and health information technology, personalized patient-centered approach, didactics and healthcare delivery systems, specialization opportunities, especially obstetrics and gynecology, makes family medicine my choice of specialty. My clinical career has been shaped by medical education and United States medical licensing examinations course of Step 1, Step 2 clinical knowledge, Step 2 clinical skills, Step 3 scores of 88 or 212, 98 or 257, pass 88 or 212, and improved with clinical rotations in the United States of America at Atlanta Medical Center and Crawford Long Hospital, Atlanta, Georgia. Observerships at Texas Health Harris Methodist Hospital, Fort Worth, in internal medicine with Dr. Fidelis Nini, and Huntsville Family Medicine Residency Program, Huntsville, Alabama, in Family Medicine in-Training Service with Program Director Dr. Mary Cristali, MD, and the inpatient team. Externship at Resurrection St. Elizabeth Hospital Family Medicine Residency Program in Family Medicine with the Program Director Emeritus Dr. Saida Zahibi, and graduate medical education training at Henry Ford Internal Medicine Residency, and Southern Illinois Family Medicine Residency Program, Springfield, Illinois, with inpatient, outpatient, and obstetrics and gynecology rotations with program directors Dr. Kimberly Baker-Jinal and Dr. Janet Albers. I'm continuously updated with graduate medical education and caregiving in Dallas, Texas, and enhanced with a Master's in Business Administration, Core Public Health Administration, and ongoing public health at Katana University, Minneapolis, Minnesota. Collaboration with the American College of Physicians, American Academy of Family Physicians, American Psychiatric Association, American Pediatric Association, American Congress of Obstetrics and Gynecology, with current practice recommendations, which have improved my Accreditation Council graduate medical education core competencies tremendously, with core skills of comprehensive history and physical as a prospective intern in the graduate medical education program. Continuity Clinic was an enjoyable, collaborative environment with diverse patients, including the 50-year-old Caucasian male who came to the Continuity Clinic and said, "I have knee pain" as a chief complaint. with history of present illness of difficulty performing activities of daily living, joint pain, fever, malaise which is worse in the morning, past medical history of hypertension for 10 years, current preventive care, social history of college graduate, teacher, living alone, single, social drinker, and ibuprofen 800 milligrams once a day orally as needed for pain, and no non-drug allergies, concordant review of systems, and physical examination findings of inflammation, deformity, reproducible pain on palpation of the joints and of the joints of the upper and lower extremities, and decreased range of motion, differential diagnosis of fibromyalgia, Lyme's disease, myelodysplastic syndrome, osteoarthritis, paraneoplastic syndromes, polychondritis, polymyalgia rheumatica, psoriatic arthritis and sarcoidosis. Laboratory orders of comprehensive metabolic panel, complete blood count, erythrocyte sedimentation rate, C-reactive protein level, rheumatoid factor assay, anti-nuclear antibody assay, anti-cyclic citrullinated peptide, anti-mutated citrullinated vimentin assays, and C-reactive protein. Imaging of involved joints, including radiography, magnetic resonance imaging, ultrasonography of joints, joint aspiration and analysis of synovial fluid for gram stain, cell count, culture and serum glucose, assessment of rheumatoid arthritis and treatment plan of heat and cold therapy, culture and serum glucose, assessment of rheumatoid arthritis and treatment plan of heat and cold therapies, orthotics and splints, therapeutic exercise, occupational therapy, adaptive equipment, ibuprofen, Advil 800 milligrams orally every 4 to 6 hours, methotrexate, Trexel 7.5 milligrams orally as a single weekly dose, follow up in 1 month, coding of ICD-9, ICD-10 714.0, M06.9, and billing of 99214 for established patients with detailed history, physical examination, and moderate complexity decision making in 25 minutes. It was amazing to see the changes which occurred in the past few weeks in the 15-year-old Caucasian male with caregiving, incorporating occupational therapy, speech therapy, and physical therapy with past medical history of cerebral palsy, whose chief complaint was abnormal muscle tone, asymmetric crawling or failure to crawl, growth disturbance and failure to thrive, and gross motor developmental delay, which has improved progressively over the past few months, and family history of genetic disorders, and current preventive care on baclofen, 15 milligrams twice orally, and phenobarbital 100 milligrams per 10 milliliters, and no known drug allergies, with concordant review of systems and physical examination findings of decreased visual acuity of 20/200, 2 centimeters well-healed scar in the umbilical region with a gastrostomy tube, 2/5 muscle strength, decreased muscle tone and bulk, decreased coordination, normal sensory function, 3+ deep tendon reflexes, contractures, decreased range of motion, differential diagnosis of inherited metabolic disorders, metabolic myopathies, metabolic neuropathy, movement disorder in individuals with developmental disabilities, traumatic peripheral nerve lesions, tumor of the colons and cauda equina, and vascular malformations of the spinal cord, with laboratory orders and findings of cerebrospinal protein chromosomal analysis, imaging of computed tomography, CT scanning, magnetic resonance imaging, MRI, electromyography, EMG, nerve conduction studies with evoked potentials, consults with neurology leading to an assessment of cerebral palsy, with a plan of continued medications, feeding with gastrostomy tube, physical therapy, occupational therapy, and speech therapy, follow up in 3 months, according to billing of ICD-9 343, ICD-10 G80, and billing of 99205 as a new patient due to the comprehensive history. Physical examination of high complexity decision making done in 60 minutes. The 33-year-old African American was in severe distress and crying uncontrollably when she was brought in by the ambulance into the emergency room and said, "I was raped," as the chief complained 1 hour ago. History of present illness of inflicted physical injuries and unprotected sexual abuse. Past medical history of depression. Past surgical history of a cesarean section 5 years ago. Obstetric history of last menstrual period 4 weeks ago. Every 4 weeks on oral contraceptives. Current preventive care. Social history of unemployment. High school graduate, single and use of marijuana for 7 days, and no known drug allergies with concordant review of systems. Physical examination findings of severe distress, bleeding, lacerations on the face, arms, and trunk. Vaginal lacerations and differential diagnosis of blunt abdominal trauma. Abruptio placenta. Acute coronary syndrome. Alcohol and substance abuse evaluation. Soft tissue injury. Anxiety. Asthma. Vaginitis and malingering, and laboratory orders of urine or serum pregnancy test, serologic test for syphilis, hepatitis B, human immunodeficiency disease, vaginal culture for wet mouths, gonorrhea, chlamydia, trichomonas vaginalis, bacterial vaginosis, and candidiasis, procedures of colposcopy, consults of obstetrics and gynecology, and psychiatry, and assessment of sexual abuse and treatment plan of cetirizine 125 mg intramuscularly in a single dose. Metronidazole 2 grams orally as a single dose, and azithromycin 1 gram orally in a single dose, and 2 oral tablets and 2 tablets 12 hours later for pregnancy prophylaxis. Tetanus, hepatitis B prophylaxis, and counseling with a sexual counselor. Follow up with obstetrics and gynecology in 1 week, and coding and billing of ICD-9 E96.1 T74.2, and billing of 99202 as a new patient with detailed history, physical examination of low complexity decision making in 30 minutes. It was a great learning opportunity in obstetrics and gynecology with the team at Southern Illinois University Family Medicine Residency Program, when the 33-year-old Asian female came in and said, "I'm having uterine contractions." And a headache as the chief complaint with history of present illness of uterine contractions every 5 minutes. Rupture of membranes with medium amounts of clear amniotic fluids. Fetal movements every 5 minutes, lightning, changes in breathing, frequent urination and no vaginal bleeding, past medical history of urinary tract infection, obstetrics history of first gestation, no preterm, 10, aborted or live pregnancies, current preventive care, social history of marriage, physician, graduate school, living with husband and exercising 3 times a week, and no known drug allergies, concordant review of systems, and physical examination finding of hypertension, cephalic left occipital anterior presentation, contractions every 5 minutes, and a fetal heart rate of 150 beats per minute, and a digital vaginal examination results of 10 cm cervical dilation, 100% effaced, anterior cervix with a firm consistency at 0 stations, differential diagnosis of normal labor and pregnancy, preeclampsia, urinary tract infection, cervical lesions, ectopic pregnancy, myomas, and ovarian tumors, and laboratory orders of complete blood count, blood typing and screening, urinalysis, serum alanine aminotransferase and aspartate aminotransferase AST levels, creatinine, uric acid, 24-hour urine collection for protein and creatinine, peripheral blood smear, serum lactate dehydrogenase, LDH level, indirect bilirubin, coagulation profile, prothrombin time PT, activated partial tromboplastic time APTT, and fibrinogen, imaging of head computed tomography, transabdominal ultrasonography, umbilical artery Doppler ultrasonography and cardiography, pulling test, nitrazine paper test and FEM test, which are usually performed, imaging of external glucometric monitoring and or intrauterine pressure catheter, bedside ultrasonography, cardiography, electronic fetal monitoring, fetal scalp electrode, fetal pulse oximetry, procedures of establishment of intravenous IV access, consults of obstetrics and gynecology, the assessment of labor and delivery, pre-eclampsia, and treatment plan of delivery and pain management, labor augmentation and blood pressure control with meperidine 25 to 50 milligram, oxytocin 1 milli international unit per minute intravenously, and hydroxyzine 5 milligram intravenously, and delivery of the